Så er klokken 8. Kan I høre mig? Godmorgen til jer her i Milorstrup-salen. Godmorgen til alle dem, der er med på livestreaming. Jeg hedder Lund. Jeg er stabschef for kvalitet, forskning, innovation og uddannelse på OH. Og det er en glæde at kunne se frem til i dag, hvor vi har Adverse and Traumatic Events from the Perspective of Healthcare Professionals Supporting Our Second Victim Colleagues, som er temaet. Det er personalet, der er temaet i dag, hvor vi jo normalt har patienten først. I dag der kigger vi på personalet. Vi har besøg af Hanan, Edrees, som har arbejdet med quality and safety i mange år. Der står godt nok også, at Katja Skrøder på. Hun kommer alligevel ikke på, men hun er med her i salen og kan bidrage til debatten. Hanan har lavet et joint project i The Body Study, som hun vil fortælle om, og hun har deltaget i et RISE-program af John Hopkins University i USA. Det handler om personalet og et støtteprogram i forhold til, når personalet har været udsat for utilsigtede hændelser og traumatiske hændelser. I would like to give the word to you, Hanan, and you can present yourself and say a little about your background. Welcome.
Good morning. Can everyone hear me? Okay. All right. My name is Hanan Edrees. I'm a faculty member at Johns Hopkins University. I'm also working at the Ministry of the National Guard Health Affairs in Saudi Arabia at the Children's Hospital. The King Abdullah Children's Hospital was established a couple years ago, and I was brought in to help develop the quality and patient safety infrastructure there. Previous to my move to Saudi, I was working at the World Health Organization, supporting the Ebola crisis, so working a lot on infection control and helping advise governments on quality and safety. And prior to that, I was working with the Johns Hopkins Armstrong Institute to look at patient safety and quality projects internationally. And I was also part of the RISE team. So the RISE is a second victim support program that was led by myself, Dr. Albert Wu, Ms. Lori Payne, who's our Director of Quality and Patient Safety. And what we've done back in 2010 is start the program. And so what I'll talk to you today is about the second victims. I always like to start out with a story, and expectations run high in healthcare. Many times we're asked to be perfect. We went to medical school, we don't make mistakes. We went to nursing school, we know everything. But what we want to understand is that Kimberly Hyatt was a victim of medical errors. Kimberly Hyatt was a nurse for over 20 years. She was involved in a medication error that included a 10-fold overdose of a fatal drug, which is a very common error. But unfortunately, within 24 hours, her patient had died. Kimberly was dismissed from her job. She was not given the opportunity to understand what went wrong, and she was not allowed to practice until the investigation was complete. And even though we think about the nurse in this situation, what we need to do is we need to ask, what about the doctor who prescribed this medication or who wrote this medication? What about the pharmacist who dispensed the medication? And what about the processes or system failures that happened during this time? We need to ask these questions. Unfortunately, after 10 months, Kimberly committed suicide. There was news all over that talked about the organization handling this event very well. But unfortunately, we can see by Kim's actions, she's no longer with us. So what does that tell us as healthcare providers? We really need to care for our own. And if we don't care for our own, we're unable to take care of our patients. So when a medical error happens, and medical errors happen internationally, the first victim is generally the patient or the family members. And the second victims are the healthcare providers who are involved in this event. So many times, second victims feel that they're responsible, they feel that they're incompetent. They also second guess their clinical skills and knowledge, which shouldn't be the case. What we need to understand is that we have systems that fail us sometimes. We have highly skilled healthcare workers that are working in systems that are not so catching up with the times, if you will. And so many times, our second victims have experienced similar signs and symptoms related to post-traumatic stress disorder. So some of these can be short-term, so they can last for a couple days or a couple weeks. But then in severe cases, some of these can be very long-term. So we're talking about social withdrawal, we're talking about anxiety, anger. Everyone reacts differently to these types of events. But what we want to understand is how to manage these events. We also want to keep in mind that as healthcare providers, we're already burned out, as it is, right? Many of us can relate to experiencing some of these symptoms as well. Being pessimistic, not being adamant about the future, loss of satisfaction of work, trying to leave the work environment, trying to go into administrative positions rather than seeing patients. All of us, I think, can relate to some of these. But when we think about medical errors, this does not only have an impact on an individual or the patient. It also impacts the organization, it impacts the healthcare team, and it also impacts our lifestyle. So when we're looking at how common is this problem in healthcare, is it an international issue? Is it only in our hospitals here? We found that there were several studies, not too many, when we compare them to the medical literature, but the prevalence goes anywhere from 10 to 50%. And you can see from the table here that the populations differ, the focus or the scope of the studies differ. So what we need to do, I think, as healthcare providers is perhaps take a deeper look and try to really understand how common this problem is. Again, there are limited studies on second victims, but there are studies that have been done in Switzerland, in Belgium, the United Kingdom, Sweden, Italy, and I know that there's some work being done here in our hospital in Denmark. And there are descriptions of organizational support programs that are out there. Some have been published, some have not been published. There's little documentation of the steps involved in their development. So sometimes we just set up a program and we hope that it goes well, but we're not there to accurately measure the impact. And then sometimes we have limited resources for evaluating the feasibility and effectiveness of these programs. So is this working well or is it not working well? Are we really using our resources the way we should? So there's a history of how the second victim is impacted, right? So we talked about the initial response to the incident. So some people can have short-term symptoms, some people can have long-term symptoms. But then there's also a factor that impacts the way healthcare providers are feeling, and it's the way our peers are feeling about us. Are they being judgmental? Are they being supportive? Of course, after a medical error happens, there's always an investigation that takes place. So that can either positively impact the second victim's experience or can negatively impact them. And then, of course, sometimes in some situations, it can go to court. So it could be a malpractice suit, or I think in Denmark here we have a national complaint system. So that can also impact the healthcare provider's psyche, but then also their career as well. So there's a trajectory of recovery for second victims. So there is positive that comes out of all of this. But if we want to look at something a little deeper, I'm trying to find this one right here. Yeah. Okay. So I understand we're not going to read through the entire chart, but here it talks about the different stages or the trajectory of recovery for second victims after a medical error happens. And we can see here from stage 6, we want our healthcare providers to move on after the medical error, right? So there are 3 ways that they can move on. They can either drop out, so they transfer to a different unit, they leave healthcare altogether, they go into administration, they leave the hospital. So these are when second victims are not doing so well. They can survive, so they can cope, but they're still thinking about the medical error every time they see a patient with similar symptoms, for example, or someone with similar demographics. Or what we want to focus on is the second victim can thrive, so they can maintain a strong or balanced work-life balance. They can gain insight or perspective into what actually happened and how the system can prevent the same error from happening again. And what I'll talk to you today is about what can we do as healthcare providers in the field to help our second victims thrive, because we don't want them to drop out. And although we want them to survive, we really want the best for them. So we want to focus on thriving. So some of us can do better, but we're still feeling worse. We're still feeling worse because we're feeling that we're being thrown under the bus. We're feeling that our organization was not supportive. So I talked about Kimberly Hyatt earlier this morning, and her organization dismissed her from her job rather than bringing her in and asking her what went wrong. Was there a disruptive colleague, for example, during the time that you were giving the medication? Did you incorrectly read the dose? What exactly happened so we can prevent the same error from happening again? And so what we want to do is to make the case for peer support. We want to make the case for peer support programs because we asked second victims many, many times what would be helpful for you. And they said, if we reached out to a colleague, it would be very supportive. It would be very supportive rather than speaking to a family member, rather than speaking to a professional counselor. And so what we did was we looked at the state of Maryland in the United States, and we wanted to assess the need. We wanted to gauge a little bit about what does the prevalence look like? Do we have a lot of second victims, or is it only in our hospital at Hopkins? And so what we did was we looked at developing interview questionnaires, and we conducted semi-structured interviews for 43 participants from 38 acute care hospitals. And the participants were mainly healthcare providers in leadership positions, so perhaps a director or a chief quality officer who oversees adverse events and how they get handled, someone who is developing the quality and patient safety infrastructure in their hospitals so they have an oversight of what happens. And so we had an 83% response rate. And there's two parts to this. The first thing we did was we wanted to assess the extent of the second victim problem. So do you see that this is a problem in your organization? We wanted to determine the availability of emotional support services. So if you do see that there's a problem, what are the chances that you have a structure in place to help support these individuals? We wanted to assess the need for organizational support programs. So would this be helpful for your staff to help thrive in their role? So the results were very interesting. So all the participants said that the second victim was a problem in their organization, and they all said that their executives were aware of it. However, when we asked additional questions, they said, we just don't know how to deal with it. And so if there is an organization or there are a group of people who can help us support a structure or develop a structure, that would be very helpful for us. And what they also mentioned was that there was still stigma associated with accessing such support. So if it was anonymous, if it was confidential, that would be very beneficial to employees. The second part of this study was that we wanted to describe the extent to which organizational support for second victims is perceived as desirable by the second victims themselves. And we wanted to identify existing support programs. Because as I mentioned earlier, there's very limited literature on the second victim programs. And so if there's an opportunity for us to collectively get these ideas and put them on the table, it might be helpful for other organizations to learn from. So we realized that all hospitals offered employee assistance programs. And employee assistance programs are confidential, short-term counseling services for employees with personal problems that affect their work performance. So one example is substance abuse. And what we wanted to focus on mainly was the second victim. So not necessarily problems that you're facing at home or that you're facing with your spouse or your loved one, but an issue that you're dealing with after a medical error had happened. So there were no valid measures in place to assess the effectiveness of these services, and participants identified a need for peer support, both for the second victims and for the individuals who provided the support. So even though we wanted to support our second victims, those individuals who are supporting the second victims needed support as well. And we found that only 6 out of the 38 hospitals had support programs. So that's a very small percentage. So we stepped out of Maryland. And we looked and we asked colleagues what their programs were including. So for example, the Medically Induced Trauma Support Services, or MITS, it's a nonprofit organization that really promotes support for second victims, for patients and their families. They also have a hotline where patients and providers can call and get support. So it's open for everyone in the state of Massachusetts. And it was started by Linda Kenny, who was a patient. And she suffered from a medical error, but what was interesting about Linda was that she thrived. She partnered with her physician, and they both started the organization together. And now they're helping hundreds of thousands of second victims as well. The University of Missouri also founded the 4-year program, which is a peer support program. It's well established as well. Kaiser Permanente has also started a program as well, and it's the largest US integrated health system, and it's located in California. And it realized that one of the barriers to reaching out for support is the stigma associated with accessing formal support through the EAP structure, or the Employee Assistance Program structure. So they developed a situation management team that partners with their Employee Assistance Program and really helps support the second victims. At Boston Children's, there's the Office of Clinician Support, and the Quality and Patient Safety Department works with the legal office. They work with all hospital departments, so they have a multidisciplinary approach to tackle this issue. Brigham and Women's at the Center for Professionalism and Peer Support wanted to really maintain a culture of trust and respect among healthcare providers and their families. And they realized that they had a lot of unprofessional and disruptive behavior, so they coupled that with support for caregivers, support for colleagues, and support for peers as well. And then I'll talk to you today about the Johns Hopkins Hospital program, RISE, which is Resilience in Stressful Events, and we started that back in 2010. And then, of course, if you look into the literature, there are other types of support for psychological trauma. So there's psychological first aid, there's some support that's given in the military, etc. So I mentioned earlier that we have some work that's being done by one of our colleagues here. Oh, let me go back. And that's going to be called the Buddy Study. So if you have any additional questions, Dr. Schroeder would be happy to help you with those questions. I think there's some work being done with the Department of Obstetrics and Gynecology, along with some collaboration with the Department of Oncology. So I think it's a very, very exciting time to participate and to ask questions and be involved with this program. So I'll give you an overview of the structure that we have developed. And of course, I want us to keep in mind that every organization is going to have a different program, because what we want to do is we want to look at our existing resources. We want to leverage our existing resources and bring them together to see how we can support the second victims. So it's not bringing another program and copying and pasting it into our organization, but rather using the infrastructure that we already have. So Johns Hopkins Hospital is located in the state of Maryland. It's a 1,000+ bed hospital. And what we had was, we had several patient deaths, and we had very severe sentinel events that had happened, and the leadership decided to do something about it. But how exciting is it here, in our hospital here today, that we don't have to wait for something bad to happen. We want to start before it happens, and we want to prevent it from happening. So we looked at our infrastructure, and we found that we had several departments that were offering several different services, but nothing that was specifically tailored for the second victim. And we asked staff, because that's the best way to do it. We asked staff, what do you think will be helpful for you? And many people said that a peer support program would be helpful if it was anonymous, if it was confidential, if it was accessible. So our employee assistance program was not accessible. It was only available from 9 to 5, and we know that most errors happen after the workday is over or during the weekends. And so we came up with this program with a mission to provide timely support to employees who encounter stressful patient-related events. And we wanted to increase the awareness of the concept of second victims. We wanted to provide multidisciplinary, so one-to-one or individual or group support. So if there's an incident that happened in the unit and several healthcare providers were involved and they were all affected, we could provide that type of support. And we wanted to also equip managers and employees with a general understanding of how to respond to a second victim if they're not feeling well. We also wanted to reassure and guide employees to continue to thrive in their role, and that these things happen in healthcare, but we have to stick together in order to improve the situation. So we developed the program through 4 phases. The first one was really to assess the need, as I mentioned earlier. So we realized we wanted to do a peer support program. We brought in the right people at the right time. So we had a multidisciplinary team. We had people who were very approachable. we recruited and trained peer responders. So peer responders would be supporting the second victims after the error had happened. So for example, these individuals were very well known to be in the organization, to be non-judgmental. They were the go-to person if somebody had an issue and they were able to help. And they were very open and honest and very supportive. And everyone in their hospital knows who these individuals are, and they're generally the go-to people. So it doesn't necessarily mean they're in leadership positions, but they're informal leaders. So everybody is very familiar with their reputation as being very supportive. We invited these individuals to be peer responders, and we then later launched the RISE pilot in the Department of Pediatrics. And then after that, we became very successful. We were getting questions from other departments. How can we have access to the RISE? We need to really access the services. We rolled it out to the entire hospital. So what happens is when a medical error happens, there's a RISE pager that is activated. It's open 24/7. And either the second victim themselves or their colleagues or their supervisors can recommend them to access the RISE services. The peer responder meets with the second victim, and then they are able to take the lessons learned from that interaction and share it with the rest of the team. So we de-identify the situation, but we use it as a learning experience to understand what went wrong and how can we help support not only the second victims, but the individuals who are supporting the second victims. So what does RISE do? RISE is very supportive. It facilitates existing resources in the hospital. So as we were putting this program together, we didn't realize that we had massage therapy that was being offered to staff. So that was very helpful for some second victims to go through. We also had a wellness program, so some staff felt like maybe eating right was helpful for them after a situation. They felt that maybe a little bit of exercise, or if they were able to go to a gym and get discounted membership, that would be helpful for them. So these were all services that were offered by the organization, but they were very hidden because no one knew about them. We were able to provide 24 access for support, and then, as I mentioned earlier, individual or group support. What we want to also keep in mind is that RISE does not employ counselors or psychiatrists. This is a volunteer program, so peers helping peers. We don't really investigate or take the details of the event, rather the feelings of the healthcare provider and what we can do to help support them. And we definitely don't fix any employment problems. And you might ask, what type of training do these individuals go through? So they went through psychological first aid, and I'll talk to you a little bit about that in the next slide. But then we also had peer responder meetings. We did some role play. We did some reflections on stories. We shared some of the stories. For example, we talked about Kimberly Hyatt's situation, what could have been done differently by the organization so that we could learn from that. And we also had debriefings. So after the second victim was being supported by their peer, they would go back and share that experience with others as well. So if we look at the continuum of care, many of us are very familiar with the bottom half of this slide. So when we're looking at first aid, we think about putting the Band-Aid before we elevate to a higher level of care. And when we're looking at psychological first aid, which is what we trained our peer responders on, we're kind of doing the same thing. We're putting the Band-Aid, we're recommending them to use additional resources that would be helpful, and then we're also recommending them to seek a higher level of care if it's helpful for them. So we're not necessarily providing, it's not a patient to provider relationship, rather it's a peer-to-peer, and it's really just putting the Band-Aid until something better can happen. So you might ask, okay, so we had great solutions, we had very interactive discussions, but what is the financial impact on this organization? So if we just look at nursing staff, okay, we didn't really look at physicians, but if we just look at nursing staff, this study came out and they said that there's a net monetary benefit savings of almost $22,000 per nurse who activated RISE. Okay, and what they did was they did an economic evaluation on the cost benefit for accessing RISE over 1 year. They looked at the cost of running drives, which is using available resources or infrastructure, so it's not going to cost a huge amount. They looked at nurse turnover rates. They looked at nurse time off after a medical error happens. They also looked at costs and probabilities of quitting or taking time off after an event had happened. And they estimated these. And they found that the hospital could save approximately $1.8 million. So that's huge. I mean, these are the types of costs that we don't really see, but when we quantify them, they make a huge difference. We did a lot to spread the word. We had several campaigns. We wanted healthcare providers to become aware of the problem. We realized that the leadership was very aware of the problem. We wanted our frontline staff to become very much aware. And so we had the pager everywhere. We said it's accessible. You know, people asked us, is it only a 9 to 5 service? We said, no, it's accessible anytime. And not only did we spread the word in our own hospital, but we spread the word internationally. So one of my dear colleagues, Frank Federico from IHI, we looked at how to engage organizations and how to summarize what has been done in the literature and across the world and share with the organizations what they can do. So if we think about how can your organization participate? So first of all, what we could do is we could acknowledge that there's a problem of second victims. And when errors happen, we want to encourage staff to become involved in system changes. So in Kimberly Hyatt's story that I keep referring to, it would have been nice if we understood what had happened and what can we do to prevent this event from happening again. We want to hold debriefings and offer training sessions and formal organizational support and coping strategies for individuals. We want to develop a multidisciplinary second victim support program because it's not just one discipline that's being involved. When we take care of a patient, we take care of them as a whole, and so we want to treat this strategy the same way. But even if we don't have an infrastructure, or until we have an infrastructure, what we want to do is we want to think about how can we train our staff to be more compassionate? How can we train our staff to be very active listeners? So there are things to say and things not to say. So something that would be helpful is asking a second victim, are you going to be okay? How are you coping with this? And how have you coped with stress in the past? Perhaps that might help. We could say things like, let me tell you about a situation that happened to me. But what we want to avoid saying is, did you realize what happened? How could you have done something like that? Or I think worst of all, sometimes we don't even say anything. Silence kills sometimes. So what I'd like to leave you today with is a poem from a dear colleague of mine and dear friend, Dr. Abdurrahman Jazia. He's a chairman of oncology at the Ministry of National Guard, Health Affairs. And I'll read this to you. But it says, I walked into your room and here you were, lying down there, yellow skin and swollen face. You peeped at me with jaundiced eyes. You were still gracious as I knew you all the times. We exchanged comforting looks. I needed them too, as much as you did. Your weakened voice declared that you were still there. You did your best, Doc. You're still my favorite. I felt my inside shivering. How can I be empathetic yet not cry? Do not push more buttons, please, so they don't flood the eyes, as it may not be good for the young doctors around watching the drama unfold, watching how someone would die, yet be gracefully thankful, how the dying comfort those who stay behind, how a man who is supposed to heal let his patient say goodbye, how the partners in such a struggle depart from each other at last. So many of us can relate to a similar situation where a patient has died or was a second victim of a medical error. So I think it's now our duty and our job to come together to support second victims and spread the awareness and develop an infrastructure so that we're prioritizing our own so that we can take care of patients. I'd like to thank our colleagues for the generous invitation today, and I'd like to also thank my RISE colleagues at Hopkins and the Maryland Patient Safety Center for all their support and their work. And I'm happy to take any questions. Thank you for your time.
Thank you, Hanan. Very inspiring. I think we can do a lot more than we do today. And remember out there, ask questions at hashtag OH Talks. And then I would like to start here. Anybody? Questions?
Yeah. Thank you for a very... Does it work?
Yeah.
Okay. Thank you for a very interesting talk on a very important topic. I would like to ask you, when you did your research or when you did your studies or you talked to the second victims, did they ever attend the hospital investigation in the era? Or, I mean, we sometimes do like we call a root cause analysis, where people join in, the second victims join in. And sometimes we're a little bit... we think a little bit, is this a good idea or is it not a good idea? And sometimes it can really be helpful, but in other times can also be very hard. Did any of the people you talked to, did they join in these investigations?
Sure, so that's a good question. One of the beauties of working in a multidisciplinary group is that we had our risk manager very much heavily involved. And so what he was telling us, Dr. Natterman, he said that many times as I'm doing the investigation and the root cause analysis, one of my physicians, one of my nurses just starts to cry. And it's hard for me to focus on the facts when I'm dealing with the emotions. And so he was very happy to see that we supported a program like this and started a program like this. So in terms of the second victim program, we only focus on how the second victim is feeling after the event. But we decide not to focus a lot on the details. So they're two separate paths. So we have the root cause analysis path that happens to get the facts, but then we also transfer or refer the second victims if they need additional support to the RISE program. So it is helpful to get their input, but I think it's two separate paths, but yes, parallel and...
to join in, but it's better just to get the results.
Yeah, so to do both, yeah. So to be involved in the investigation, but then if that's also necessitates additional support, they can also access RISE.
Can I ask one more thing?
Yeah.
No, I was just wondering if the time frame makes a difference. Like sometimes it can take a really long time to do the investigation because people's calendars are booked out and stuff like that. So do you have any idea if the time frame makes a difference in these matters?
Sure. So I think sometimes we leave it up to the second victim. So sometimes people want to speak to someone immediately after it happened. Some people want to go for a walk and come back. And some people want to take a week off and then they want to share their story. So I think it depends on the individual. But what we wanted to do as an organization is make it accessible and available anytime. So anytime you're ready, we're happy to support you. Alongside of that, the investigation, as you mentioned, it can bring about many meetings, but then there's also recurring feelings. So the second victim is very happy, or we welcome them to contact us more than once. But if we feel that they need additional support, we recommend that they see a counselor, a professional counselor. We're just putting the Band-Aid on the situation until something else can be resolved. Yeah, thank you.
I was wondering, is there a difference between the staff, the nurses, the doctors, others about asking for help in these situations?
Is there a difference between
the staff, the doctors asking for help, or the nurses asking for help?
Okay.
What are your experiences?
Sure. So we thought that physicians, because of ego issues, they wouldn't access the program. But we were wrong, because our first call was by a physician. He said, I felt really bad. I had a pediatric patient, and they explained the story. But then we came to find that perhaps nurses are more collaborative generally with their work environments. They work more in teams. And so we thought that they perhaps had a stronger affinity to support themselves, so they didn't need to access the RISE program. But no, we didn't find that there was a difference, but we were just surprised that the first call was from a physician. We were very happy, actually. Actually, most of our leadership, we have physicians on our side as well. So it doesn't necessarily mean that there's a difference between profession, so it's accessible by everyone. Yeah, thank you.
Do you expect a cultural difference between the RISE program and the body study? Do you expect that, or do you think you said that you can't just implement it as such, but need to adapt to the cultural and the institution as such? But do you think there's a cultural difference in how to accept and how to approach this one?
Sure. So I'm assuming there should be a cultural difference. And I'm thinking about some of the work that we do with patient safety culture and measuring culture. So there were many studies that were done in the Netherlands, for example, and the US, and then some of the Asian countries. And they looked at the cultural differences in terms of speaking out, so reporting errors. So, from some cultures, they're very more open to speaking out based on their nature, and they do that. And then some not so much. So you have to kind of tailor the program. So I'm assuming that those experiences can be shared. But then also there's a difference in the legal system. So when we're looking even from within the states, we have state to state, there's a different legal system. So we also have to adjust or tailor the program based on that as well. So there might be some cultural differences. I think it would be interesting to see how that would play out. Thank you for your question.
I noticed that you use the term stressful events and not just adverse events. Could you elaborate on that? And where is the limit between general stressful experiences in everyday life, caring for the dying, for instance?
Sure.
Where do the limits go of your program, and what might also be needed just in terms of preventing burnout in general?
Okay, sure, thank you. When we started the program, we kind of struggled with what term exactly to use. Did we want to only include medical errors? Do we want to include adverse events? And we didn't want to limit ourselves, so we left it open. And so that's where we had stressful patient-related events. So sometimes the healthcare provider was a second victim in the situation, but nothing necessarily happened or impacted the patient. But the care itself was stressful and caused the same types of symptoms. So it caused burnout, it caused the short-term or the long-term symptoms that I talked about earlier. So we kind of left it generally open. I think as the program progresses and as we're seeing more types of specific events, we might change the scope as well. So I think it just depends. Yeah.
I can see that on Twitter we have a question from Christian. Have you considered another term than victim? Did you have any reflections on that?
Mm-hmm. So there's a study I think that's being published now that they looked at the term. They said, do we need to say victim? It's a very negative connotation. I think the term was coined by Dr. Albert Wu back in 2000, and it caused a lot of people were talking about it, but no one really did anything until early 2004, 2005. And so what we want to understand is it's good to use the term for now to just increase awareness, keeping in mind that it might be changed later. So it's good to capture awareness and identify a specific incident as a second victim, but it might be changed later, and that's okay, because I think the idea is just to support the healthcare providers regardless of what term we're using. Thank you for your question.
I was thinking about Katja. Do you have any reflections about this study we are going to start in OH? You can share.
Well, obviously, we have shared reflections, Hanan and I, about this, and we have many similar thoughts here in Denmark about the program. What we're starting the body study in OH is slightly different because the peer responders are going to be all staff members, really. It's not going to be a selective team providing this care. It's going to be whoever you choose to be your personal buddy after stressful events. Yeah. So that's going to be the main difference. But except from that, I think the fundament of this program is the same as the RISE program. So, yeah.
Very good. I'm looking forward to it, actually.
Yeah, we are as well. And we are very happy to share this with you.
Yeah,
so.
Yeah, I just had a question. Is it possible to transferring the results from Hopkins to OUH? Do you think that?
Sorry, I missed the first part of the question. About, is it?
Is it possible to transferring the results from your study in Johns Hopkins to our place in OUH? Do you think that? Or you said something about you just couldn't do it at the same way.
Yes. So that's a good question. I think we can definitely. So we published a study in the BMJ Open that details exactly what we did. So if that would be helpful, you know, I think Katja and I had a conversation about that as well. But one of the things that we want to think about is what can we do to minimize the cost, but then also make the program sustainable over time. Because many times we borrow programs, we start them and they launch and they're going really well for the first year, but then they kind of fall off because they're not sustainable. So if we're using existing resources from the organization, then they're more likely to be sustainable. But it could be probably easier even just to bring the program along and seeing how we looked at the 4 phases that I talked about, how they would work in Denmark. But again, I think it just depends on what's best for the organization.
Hello, Hanan, and thank you for a lovely presentation. My name is Shady, and I'm a patient safety representative at the Department of Radiology. My thoughts about this is resilience is interesting in the fact that you actually can get up after a fall, but I wonder, what are your thoughts about how to prevent some of these? After these studies done, can we do anything to prevent the fall itself so it doesn't happen as quickly as someone maybe quitting his job or something like that?
Okay. So your question, sorry, just to make sure I understood the question, it's to make sure that we're learning from our mistakes so that they don't happen again, or?
Yeah, and the fact that resilience is getting up after the fall, but could we do something to effectualize the robust of a human to be able to cope with situations that we know might happen in the field of healthcare?
Yeah. Thank you for that question. Dr. Brian Sexton does a lot of work on resilience and wellness and making sure that staff are not being burned out. So there's a lot in the literature on resilience and what we can do to really help build that into the system. I think it just takes different strategies. I mean, there are many strategies out there. So some things, like I mentioned earlier, it could be healthy eating or making sure that staff are involved in certain activities. It's, maybe doing 10-minute yoga exercise in the morning with the staff, during a staff meeting, at the beginning of a staff meeting, at the end of it. Just kind of reminding staff that if you feel burned out, please just stop and let's see how we can manage it together. Or just building strategies in your workflow so that you're not stressed out. So mindfulness is another example. We trained our staff on mindfulness as well. So there are many strategies out there. I think it just works, just helps to see what works for your organization. Thank you.
Thank you. My name is Elizabeth. I'm a sociologist and very interested in contemporary medical culture. And just also as a comment on your comment, did you consider incorporating or implementing this RISE program or similar programs into undergraduate or graduate or even residency programs so as to change medical culture? Because it seems to me that this is also a response of a culture where you have hardships in confronting suffering, human suffering as an existential condition.
Mm-hmm. That's a good question. I think, if we even look at the broader picture, we need to start incorporating quality and patient safety into our medical education and undergraduate. So I think as part of that, it should be, we should look at second victims and burnout and support. So I know some organizations in the States, they're starting to look at patient safety and quality, and they're actually having some of their classes interdisciplinary. So rather than, if you're a physician just going to medical school, you'll have classes with, nursing students and pharmacy students to understand how to take care of the patient. So that fosters teamwork. But I think among that, we also need to focus on second victims. So we don't have that now, but I think as universities and organizations are starting to educate their undergraduate students and their medical students, I think they should also focus on second victim work as well. Yeah, thank you.
I think we have a short comment at the last.
Just a very brief comment on that. Here in the University of Southern Denmark, I have done lectures for the medical students about this, and there's no doubt that the culture is that if I train well enough and if I'm skilled enough, then I'm going to be the doctor who's not going to be in this situation at any point. So we have to establish a culture where we are humble and realize that this could happen to anyone, no matter how skilled you are and how well trained you are. Yeah.
Thank you. I think you were really inspiring, your speech today, and we have a lot to work with, the culture and big potential. I think this about helping the staff, and at the same time we can optimize and using our resources better. That's really good. Thank you.
So much.
Vi klap.
Thank you so much.